Great, so good afternoon, and it's my pleasure on behalf of our study team to present Ledipasvir, sofosbuvir for 12 weeks in patients co-infected with hepatitis C and HIV, and this of course is the ION-4 study. These are my disclosures. Ledipasvir is a once daily administered NS5A inhibitor. Sofosbuvir is likewise a once daily orally administered nucleotide, and combined this makes for a once daily oral fixed dose regimen that is now widely used in many regions around the world. Liver-related complications remain a leading cause of death among HIV hepatitis C co-infected patients. So clearly safe and effective oral treatments compatible with multiple antiretrovirals are needed for the eradication of hepatitis C in the co-infected population. The aim of this study was to evaluate the efficacy and safety of Ledipasvir sofosbuvir for the treatment of hepatitis C in patients co-infected with HIV-1 who are currently on antiretroviral therapy. This was a single-arm study that recruited 335 participants to 12 weeks of Ledipasvir plus sofosbuvir without ribavirin. It was a phase 3 multi-center, multinational, open-labeled study. Genotype 1 and 4 individuals were recruited in the US, Canada, and New Zealand. We had broad inclusion criteria, including individuals who are hepatitis C treatment naive and treatment experienced. 20% had compensated cirrhosis. Platelets of anywhere over 50 or above were allowed. Hemoglobins over 100 and a creatinine clearance of 60 or more were included. They, of course, were HIV infected with viral loads that were fully suppressed, below 50, with a CD4 cell count of at least 100. The antiretroviral regimens included imcitabine plus tenofovir plus either efavirenz, raltegravir, or rilpivirine. The primary efficacy endpoint was SVR12, which was defined as having no detectable virus 12 weeks after completion of therapy. And note the assay that was utilized. There was also important safety outcomes, including adverse events and discontinuations, maintenance of HIV viral load below detection, and serum creatinine. This table describes the population that participated in this study. 335 participants, mean age was 52, 82% were male, a third of the population were black. The genotype was almost entirely genotype 1. There were 8 genotype 4 participants. 55% had previously been exposed to interferon-based hepatitis C treatments, and 20% were cirrhotic. There was a split of about half on efavirenz, 44% on raltegravir, and 9% on rilpivirine. And the median CD4 cell count was 628, but there was a considerable range of CD4 cell counts in this population. So overall, the SVR rate with this 12-week regimen was 96%. There were 10 relapsers who will describe subsequently. There were 2 on-treatment failures, one for non-adherence to medication, and one was interrupted as per investigator. There was 1 individual who was lost to follow-up for the SVR12 measure, who subsequently was found again for the SVR24 measurement and was found to have achieved a sustained virologic response. And there was 1 death. This was an injection drug use-related endocarditis with sepsis that was deemed not related to the use of Ledipasvir sofosbuvir. The SVR rates were similar in naive and experienced individuals, as well as in cirrhotics and non-cirrhotics. A host of traditional predictors for success with therapy were assessed, including sex, race, genotype, baseline viral load, BMI, IL-28 status, the presence of cirrhosis, prior hepatitis C treatment, the ARV regimen, and baseline CD4 cell count. Black race was found to have a statistically significant reduction in SVR compared to non-black individuals. So we'll explore this issue a little bit further. Overall, the SVR rate in non-blacks was 99%. It was 90% in blacks. And you can see the breakdown according to the antiretroviral regimen that the participants received. There's a PK done and other exploratory analyses to help understand this difference. There was no difference in sustained virologic response in the Hep C mono-infected patients in the ION program, which is important to note, with a 99% SVR rate in the ION 1, 2, and 3 compared to non-blacks of 96. Ledipasvir and sofosbuvir PK levels were assessed. They were similar between different ARV regimens, similar between blacks and non-blacks, and similar between patients who had previously relapsed and then patients who had relapsed and those who achieved a sustained virologic response. We are conducting GWAS studies, but that data is not currently available to present today. With regards to NS5A, there were deep sequencing done for NS5A RAVs, and 18% of individuals had the presence of RAVs. In those patients, the SVR rate was 93%, compared to 97% with those who did not have baseline RAVs. Post-treatment, NS5A RAVs were identified in 10 of 12 patients who virologically failed, and no NS5B RAVs were detected in this study. This regimen was very well tolerated and safe. There were 2 serious adverse events. Neither one was deemed to be related to sofosbuvir and ledipasvir. There was 1 death, as already described, in the endocarditis patient. And important to note that no patient had a confirmed HIV virologic rebound well on this 12-week course of therapy. As far as side effects, in general, in recipients of this regimen, whether they're Hep C mono-infected or co-infected, typically headaches, fatigue, and diarrhea are the top 3. None of these were incapacitating or affected people's day-to-day activities. Renal function was assessed. The red line represents those patients on Sustiva, or Favirenz-based regimen. The yellow line is with raltegravir and rilpivirine in the green. As you can see, there was no change in creatinine clearance over the course of participation with dosing or in the period after completion of therapy. There were 4 patients who had a creatinine that went over the target level of 0.4 milligrams per deciliter, which roughly translates into slightly over 200 mils per liter. 2 completed therapy without any change in their antiretroviral therapy. 1 had a dose reduction in tenofovir, and 1 discontinued tenofovir. It's important to note that these 4 patients had pre-existing renal disease, and we do not believe that this was related to any drug-drug interactions between ledipasvir, sofosbuvir, and tenofovir. So in conclusion, in this phase 3 study of 335 co-infected patients, 96 achieved a sustained virologic response after 12 weeks of dosing with this once-daily single-tablet regimen. Prior hepatitis C treatment status or the presence or absence of cirrhosis did not impact outcome. And in contrast to larger studies amongst mono-infected patients, there was a lower response rate observed in our co-infected black patients, but this was 90%. Ledipasvir and sofosbuvir was well tolerated, with no treatment discontinuations due to adverse events and no adverse impact on HIV disease or its treatment. I encourage those who are interested to read the publication of this study, which is featured as of today in the New England Journal of Medicine. Finally, I'd like to sincerely thank the patients and their loved ones for participating in this study and acknowledge all of the investigators in the States, Canada, and New Zealand who contributed to the success of this trial. So thank you very much, and I'm happy to consider questions.
Great, thank you very much, Curtis. Any questions? Have you done an analysis by CD4 count? I noticed your median CD4 count was 600 or so. What proportion were less than 200? And what is your current practice in terms of timing of ART and initiation of HCV treatment? Do you wait for the CD4 count to be above a particular threshold?
Yeah, so we assessed at multiple different cut points for CD4 cell count. Keep in mind there were so few treatment failures that the regimen performed well irrespective of baseline CD4 cell count. So that's, the second question is a bigger point of discussion. I think historically when we were relying on interferon-based therapies, unless your CD4 count was over 500, the best bet was with treating the HIV first and driving the benefits of HIV and Hep C, and then turning your attention to Hep C. I think these days, with a very well-tolerated, short-duration therapy, there's a lot to be said for offering therapy at a lower CD4 cell count, perhaps as low as 350. You eliminate the hepatitis C infection, and then you don't need to worry about drug-drug interactions with the antiretrovirals. You may help to achieve a superior CD4 cell recovery once the hepatitis C is eliminated, and you may reduce drug-related toxicities if the hepatitis C is eliminated.
Okay. Thanks, Curtis. So 3 very quick questions, microphone 2 and then microphone 4 with quick answers.
François Raffi from France. I have a dream that is, why should we have the same presentation of the same study at 3 different conferences during 5 months, CROI, EASL, and now EIS, for a very important study, but the same data presented 3 times. So I think we should try to avoid that. Apart from that, I would like to ask you, did you look at other polymorphism at the NS5B protein regarding other mutations than the S282T, because we know now that some of these mutations can impair phenotypic activity of sofosbuvir, and you always rely on these specific mutations, and you didn't say if there were any other variants.
Yeah, no, that's a fair question, and that detail is presented in the supplementary data with the publication, but no other clinically relevant mutations were identified in our analysis.
Okay, quick question 2 and then 4, and then we'll move on. Thanks.
Ricky Sue from the United States. Quickly, were there higher rates of NS5A mutations in the Black patients?
No, that was not observed as a potential explanation for that poorer outcome. But that's a really good thought.
Knut Schewe from Hamburg, Germany. It's the first time for a long time that I've seen an association of SVR with the IL genotype, which was apparently associated. Do you think this is a chance finding?
I'm sorry, one more time?
The IL-28TT was associated with a lower treatment response, and I haven't seen that for the DAAs.
Yeah, that wasn't a statistically significant finding with the multivariable analysis that was conducted. At the end, it was only black race that came out in this particular study.
Great. I think we need to move on. So thank you, Curtis.
I'm going to take the chair's prerogative and get rid of this stool.
Okay. Great. I'd now like to introduce the next speaker. This is David Wiles, who's an Associate Professor of Medicine in the Department of Medicine at UC San Diego, who will speak on